Thanks, Edwin. I think we'll move on to Dr. Gregg Stone to talk to us about next rounds of transcatheter mitral trials. Are RCTs between TEER and TMVR necessary?
Thanks, Anita. So, interesting title. Are they necessary randomized trials between TEER and transcatheter mitral valve replacement? My disclosures. So a question like this, everything with mitral regurgitation comes down to primary or degenerative mitral regurgitation versus secondary or functional mitral regurgitation. But it's a little bit silly in this regard because when you look at primary MR, here's the most recent guidelines. Basically, surgery is the king, but the excellent outcomes are with repair. So everything pushes most patients that are surgical candidates to repair. And yes, maybe TEER is going to become an alternative for some of those patients, especially some of the intermediate risk patients, but we're talking repair, not replacement. So of course, TEER right now is only recommended for higher prohibitive risk surgical patients, and those patients aren't undergoing TMVR. So I don't think we're going to see randomized trials in primary MR specifically. But let's go to functional mitral regurgitation. That's really the question where the disease is the left ventricle. And if you look at the guidelines now, the strongest recommendation for patients with isolated secondary mitral regurgitation in patients with heart failure is for TEER, and that's in patients specifically meeting the COAPT criteria. And that's in the US guidelines, the American guidelines, that's what CMS reimburses for and what FDA approved. And that's because we, unlike in primary MR, we don't have great data that surgery improves prognosis. In fact, we don't have any data. This is the data that's always shown. It's the probably the biggest registry experience of medical therapy versus surgery in severe ischemic mitral regurgitation done a long time ago by Steve Bowling, University of Michigan. No difference whatsoever in overall prognosis or mortality. And in fact, there was one randomized trial from the CTSN because repair, principally with an undersized annuloplasty ring, was being used for those patients who went to surgery. And then the 251 patient severe ischemic FMR randomized trial of repair versus replacement by surgery showed that the overall outcomes were similar, except there was a much, much higher recurrence of both moderate and severe mitral regurgitation with a repair in functional MR. And that's because there's ongoing remodeling and ongoing lack of coaptation, and the ring is not a long-term solution. So there's been a real move in the surgical community, not by every surgeon, but by most, I believe, for transcatheter mitral valve replacement if patients are going to undergo surgery. So that's really the question. Now, coupling that against TEER, and we've got a very different profile, and this, of course, is from COAPT. We had marked reductions in select patients in the COAPT trial who randomized to TEER in heart failure hospitalizations. We had a long-term mortality reduction. Patients markedly felt better, about a 16-point difference in KCCQ out at a year. Keep that in mind, about 16 points. And a real question is always going to be with TEER, since you usually don't eliminate mitral regurgitation, is 2+ an acceptable result? And if you looked at the results from COAPT, as published by Seibel Carr, if you looked at residual MR at 30 days and its impact on 2-year mortality, if you couldn't get the MR down from 3 to 4+, you had a terrible prognosis. If you got down to 2+, that's the blue curve, it seemed like it might be a little bit worse than if it's 1+ or less, but that wasn't a statistically significant difference. So 2+ isn't bad, and of course there's no indication right now to operate on 2+ mitral regurgitation. But is that an acceptable goal of a transcatheter mitral regurgitation therapy? If you look at COAPT all the way through 5 years, you can see that everybody was 3 to 4+ at baseline by Echo Core Lab, and you could see the 1+ or less was probably around 70 to 80% of patients at most time periods. But about 20% of patients had 2+ MR, only about 5% of patients redeveloped severe mitral regurgitation. But it's not 0, it's about 5%, and again, about 20% will have 2+ MR. Is that good enough? The one thing that we can certainly say about TEER is it's extraordinarily safe. It's one of the safest things that we do in the cath lab. If you look at device-specific events, there was only a 1.4% adverse event rate at 30 days, and that was it. Nothing else happens. There's no embolization, there's no endocarditis, there's no late SLDAs. It's all within 30 days, and it's very infrequent. And of course, that was all the antiquated first-generation mitral clip that we had to use in COAPT. Now, as you just heard in the last talk, we've got 4 generations of mitral clip, and this is from the Expand G4 registry. You have a variety of different arm lengths, aperture widths. The leaflets can be independently grafted or simultaneously grafted, so it gives you a lot more flexibility. And if we look at the one-year results from the Expand G4 registry, I'll show you what I'll focus on. This was 1,164 subjects between 2020 to 2022, so very contemporary. It's a mixed population, 43% primary, 57% secondary MR, and the mean STS prom for replacement was 7.6%, so expecting about a 7.6% 30-day mortality. So just keep that number in mind. And if you look here at the rate of 1 year MR reduction with TEER, let's just look at the FMR subgroup, or secondary MR subgroup. We were down to 39% back in the Everest 2 days. We went up to 67% in the COAPT days. With the third generation of the mitral clip, the first Expand registry, we're up to 93%, and now we're at 95% at 1 year, okay, with 1 plus or less with the G4 version of the mitral clip. So that's pretty extraordinary. And if you look at the 1 year mortality rates, just focusing on secondary MR, they also seem to be decreasing over time. Hard to compare this because the patients are very different, but still, nonetheless, it seems like everything's moving in the right direction. Now, let's see what we get with transcatheter mitral valve replacement. And it's still way in the early stage of this. And this is more like the Everest 2 days of transcatheter mitral valve replacement, so it's not a fair comparison, and I'm not trying to make a comparison. But here we've got just recently published, still in non-laid out version, the Intrepid EFS in 33 subjects that have now been followed out to 1 year. This is the transeptal transfemoral device. 61% primary, 39% secondary MR. Mean STS prom, 5.3%, so a little bit less. Remember, 7.6% was Expand G4. This is 5.3%. So we look at the good results at in-hospital 30 days versus 1 year, and you can really see the potential of this device. Delivery to catheter insertion and removal, on average, is about 42 minutes. It can be really pretty quick. Implant success, 93.9%, pretty good, but 1 patient needed a surgical mitral valve replacement, and 1 patient was failed and needed a TEER. ASDs, these are big devices. ASDs are being closed in 3 out of 4 cases. Is that the right thing to do? Is there any complications to that? You know, we'll see. Mean length of stay after the procedure, about 5 days, so a little bit prolonged. But this is really, of course, the take-home, and that's MR less than or equal 1 plus is 100%. And in fact, 90% is less than or equal to trace. And that is sustained out to 1 year. Fantastic results in relieving MR, no paravalvular leaks, acceptable mitral valve gradients, and the patients feel a lot better. KCCQ increased 10 points and 11 points. But there are complications. Now, death, there were no strokes. Death wasn't bad, 6.7% at 1 year. That's actually quite acceptable given this population. But there's MIs, there's a lot of vascular complications, 12% left ventricular outflow tract obstruction, 1 case needing mitral valve surgery for it. We're still learning how to prevent that and which patients to select. And I should mention, they selected 33 subjects from 234 screens, so it's very selective at this point. 6.1% of patients surgical mitral valve replacement, 1 other valve embolized. 1 patient had TEER. There's some hemolysis. There's some device thrombosis. There's some endocarditis. There's DVTs and PEs. There's a lot of major bleeding because you've got to be managed on oral anticoagulation for 6 months. There's new pacemakers, CRTs, ICDs, and a fair amount of cardiovascular rehospitalization. Some of this is obviously background comorbidity related. But it's not, you know, this is a complex device and a complex procedure in complex patients. So TEER pro, very safe, excellent clinical outcomes. But con, the procedure can be complex, as you saw, and there's a real operator dependence. Mitral regurgitation greater than or equal to 2+, and probably 10 to 20% of patients, and it permanently deforms the mitral valve. It eliminates a lot of future potential options, including transcatheter mitral valve replacement. TMVR, the procedure can be very quick and reliably eliminates mitral regurgitation. But there's more exclusion criteria, there's more procedural and possibly late complications, and there's the need for chronic oral anticoagulation. So are randomized trials between TEER and TMVR necessary? Well, of course they are. What did you think I was going to say? Okay? So, given the likelihood of greater procedural complications and the need for chronic oral anticoagulation with TMVR compared to TEER, TMVR must be shown to be more effective than TEER in COAPT-eligible patients and are more effective than medical therapy alone in COAPT-ineligible patients. The real question is not, are randomized trials necessary? The real question is, are they feasible? And here we can look at the trials that have been done, particularly the Apollo experience, again with Intrepid. And I'll show you all the trials being done. But they started the first randomized version, and they were looking at low-risk patients who could undergo surgery. And they were going to randomize low-risk patients to either Intrepid versus surgical mitral valve replacement. Well, that enrolled almost no patients because TEER was being done in all the low-risk patients. So then they switched to randomized version number 2, and they added surgical mitral valve replacement or TEER, okay, to this population. But that also was enrolling extremely slowly. And so now they've switched to the current version of the protocol, which is non-randomized. They've got a multidisciplinary heart team selecting patients not suitable for either surgery or TEER. And then there's a primary transcatheter mitral valve replacement cohort and a MAC cohort. And they're using objective performance goals of death, heart failure, hospitalization, or KCC improvement for the primary cohort. Similarly, the Encircle trial said, we're not even going to try to randomize. Let's learn from that experience. And they got FDA to agree to a single-arm registry. And again, 500 patients. The last one was 1,000. Here's 500 patients, a primary cohort, an attempted but failed tiered cohort, and then a MAC cohort. Again, objective performance goal of death or heart failure hospitalization. The one trial that is trying to randomize, what I would say is doing the right thing if possible, is the Summit trial. And they're taking patients who are COAPT eligible, and they're randomizing them to Tendyne versus MitraClip. And patients who are not, there's a MAC registry, and the MAC registries have enrolled in this and Apollo. Now they're in a follow-up cohort, and then there's a non-randomized primary cohort as well. So my last slide, I'll leave you with this. Issues arising from these single-arm trials. How rigorous will heart teams be in identifying patients that are truly ineligible for TEER or mitral valve surgery? Because this introduces the risk of including patients who might benefit from TEER or mitral valve surgery. So is it the right thing to do? Now, outside of the trial, patients truly ineligible for TEER and mitral valve surgery would be treated with best medical therapy. So why are the single-arm groups not randomizing the GDMT? And I bring up the Partner 1B opportunity. Imagine if those surgical turn-down patients for TAVR were not randomized to medical therapy. You'd see a 40 or 50% mortality in the control group, in the TAVR group, and you would have no idea if that was better than control. But because you saw it was 50% versus 80%, TAVR was a huge grand slam, and it became what it is. So randomization answers all these questions in these high-risk complex populations. And finally, given the complexities of TMV, big R and little r, devices and their complications, can a single-arm study truly gauge their safety and effectiveness compared with standard of care? So are registries with objective performance criteria, primary endpoints sufficiently precise to support approvals or guide appropriate clinical utilization of Class 3 devices? And there's no guarantee that those single-arm trials are going to lead to approval. They're going to have to get through first an FDA advisory board panel and then through the FDA. And if there's a fair number of complications, we're going to be wondering, are the effectiveness worth the safety issues? Thanks very much.